Hi everyone, my name is Nadia and I am a PhD candidate from Monash University. In this presentation, I will be discussing some of the challenges that were encountered in an upper gastrointestinal cancer data linkage study. Pancreatic, esophageal and gastric cancers are often collectively referred to as upper gastrointestinal cancers. Now, whilst they do not form a significant number of overall cancer cases diagnosed in Australia, they do, however, contribute towards a significant number of cancer-related deaths. For instance, in 2018 in Australia, pancreatic cancer was the fourth most common cause of cancer-related death, esophageal the 10th and stomach the 13th. Due to most of these cancers being diagnosed at a late stage, coupled with a lack of curative treatment options, the 5-year survival rate of upper gastrointestinal cancers is extremely low, ranging from 11% for pancreatic up to 31% for gastric cancers. You will also notice that unfortunately, the survival rate has barely improved over the last 30 years. Unfortunately, patients with upper gastrointestinal cancers also experience very high symptom burden, as well as heightened levels of anxiety, depression, poor quality of life, and unmet needs, really signifying the importance of providing these patients with timely access to supportive care. Given the poor prognosis of these cancers, as well as its high symptom burden, there are numerous difficulties when it comes to engaging patients in research. Consequently, the utility of a linked dataset in this population is of high value in order to help address important research questions, such as understanding health service utilisation, which can in turn improve service delivery and ultimately improve patient outcomes. The key objectives of this project include, firstly, mapping the patterns of health service, particularly supportive care service utilisation in upper gastrointestinal cancers diagnosed in Victoria, Australia between 2008 and 2018. And secondly, identifying the operational and feasibility issues associated with linking Australian state-based administrative and registry data. And this particular objective will form the focus of this presentation. In order to map the health service utilisation profile of upper gastrointestinal cancer patients from the moment that they are diagnosed all the way up to the end of life, we propose to link the following data sets. The Victorian Cancer Registry, which is a population-based registry from which the cohort of interest would be identified, as well as other state-based administrative data sets, including the Victorian Emergency Minimum Data Set, admitted episodes, radiotherapy, death index, integrated non-admitted health data set, community health, cost data collection, and federal level data sets, including the Pharmaceutical Benefits Schedule and the Medicare Benefits Schedule. We also propose to link some supportive care service specific data sets, including primary care, palliative care, as well as the Upper Gastrointestinal Cancer Registry. The linkage between these datasets was facilitated by the Centre for Victorian Data Linkage, which is the Victorian state node of the Population Health Research Network. However, due to the various challenges encountered along the way, a linkage could only be created between the following remaining datasets. The data linkage challenges which were encountered during this project can be broadly categorised into logistical, feasibility and data coverage issues. In terms of the logistical issues, Data access request applications varied significantly across different datasets. The process of requesting data from the state-based administrative datasets was streamlined into a single data access request application that was submitted to the Centre for Victorian Data Linkage. However, individual requests needed to be made to the other non-state-based administrative datasets. Fortunately, there were no issues encountered with the ethics approval aspects of this project, and this may be due to the fact that we, the researchers, did not request for any identifying information from each of the datasets, as the linkage itself was facilitated by the Centre for Victorian Data Linkage. However, that being said, the availability of unique person-level identifying information varied widely in the non-state-based administrative data, creating difficulties with the linkage capability of the data. Ethics and governance stipulations embedded in the data policy frameworks of certain datasets also posed restrictions. For instance, one dataset had data access policies in place which restricted the capacity to create a linkage with other datasets. Additionally, a separate dataset required consent to be sought from individual services contributing data, and this would equate to approximately 940 services needing to provide individual practice-level consent. With regards to feasibility, significant costs were associated with linking with primary care and the Medicare and pharmaceutical benefit schedules. Costs quoted for data submission and linkage ranged up to 230,000 Australian dollars. The timeliness of approval also varied according to each dataset, ranging up to 1 year from application submission. With regards to data coverage, firstly, the time period of data capture differed between and within datasets. For example, whilst many of the state-based administrative data were available for the entire data collection period, others, such as the Upper Gastrointestinal Cancer Registry, only captured a proportion of this time period. Some data items were also missing or captured insufficiently, serving as an inherent limitation of the data. Additionally, the non-administrative datasets, such as the primary care dataset and the upper gastrointestinal cancer registry, do not capture data across all Victorian services. For example, approximately half of the Victorian primary health networks are captured by the primary care dataset, and within these primary health networks, generally 20% of practices do not consent for their data to be used for research purposes. The Upper Gastrointestinal Cancer Registry, on the other hand, captures data for approximately 75% of the pancreatic cancer population in Victoria. Such variabilities in data coverage ultimately limit the quality and integrity of the overall linked data. Whilst in theory, data linkage is a powerful mechanism for obtaining population-level data, in reality, there are many logistical and financial barriers to linking multiple datasets. Consequently, critical data which has the potential to inform policy and improve patient outcomes cannot be procured. However, the availability of a government-approved state-based linkage platform, such as the Centre for Victorian Data Linkage, serves as a critical supportive platform which aids this complicated process. Some suggestions for ways in which such challenges can be overcome include streamlining the data access request application process, integrating the capacity to create linkages within individual consent models, minimizing the cost of data access, and also collecting critical, high-quality, unique person-level identifying variables from all participating individuals at the dataset inception stage, which will in turn aid the linkage process. I would finally like to gratefully acknowledge my co-authors, as well as the Project Advisory Working Group, Mr. Mark Lucas from Monash University, and the funding bodies, including the National Health and Medical Research Council and the Victorian Cancer Agency. Thank you so much for tuning into this presentation.